So again, good morning, everyone. Welcome to the Orlando GI Journal Club. This is December 6th, 2023, 7 a.m. Here in Orlando, Florida. Our first study is actually a study that we were very proud to publish in the Lancet Gastroenterology and Hepatology. This is from our group. This is a multi-center randomized trial involving centers in the United States and India, and this is our randomized trial comparing upfront endoscopic necrosectomy or step-up endoscopic approach for infected necrotizing pancreatitis. Acronym is DESTIN trial. So acute pancreatitis is the third most common gastrointestinal disorder in the United States, with 20% of patients developing necrosis. Mortality in pancreatic necrosis range from 8 to 39%, with higher rates in the presence of secondary infection. Endoscopic step-up treatment approach is associated with lower rate of adverse events and death compared to minimally invasive surgery. And the step-up treatment approach is when you perform direct endoscopic necrosectomy when there is no clinical improvement after the initial transluminal stent placement. However, this approach, we believe, necessitates a need for multiple reinterventions and prolonged hospitalization. So the aim of this randomized trial was to compare outcomes between performing direct endoscopic necrosectomy at index intervention versus a step-up approach in infected necrotizing pancreatitis. This was a multi-center randomized trial involving centers in USA and India. We enrolled 70 patients with confirmed or suspected infected necrotizing pancreatitis with necrosis extent of at least 33%, which were amenable to EUS-guided drainage. All patients underwent EUS-guided drainage of necrotic collection using a 20mm diameter Axios lumen-producing metal stent. Then the patients were randomized in a 1-to-1 ratio either to upfront endoscopic necrosectomy, where direct endoscopic necrosectomy was performed immediately after stent placement in the same treatment session, or endoscopic step-up approach, where after the initial drainage under US guidance, direct endoscopic necrosectomy or additional drainage was performed at subsequent treatment sessions if there was no clinical improvement after 72 hours. Follow-up was 6 months post-index intervention, and the primary outcome measure was the number of reinterventions required per patient to achieve treatment success from index intervention to 6 months follow-up. So this is the patient cohort. We enrolled 37 patients in the upfront necrosectomy group, 33 patients in the step-up approach group. The mean age was 46 in the upfront and 53 in the step-up approach group. If you look at the etiology of pancreatitis, the most common etiologies were gallstone, alcohol, and idiopathic in both groups. The majority of our patients were ASA class 2 and 3. The type of necrosis was walled-off necrosis in the majority of our patients, 95% in the upfront group versus 88% in the step-up group, with acute necrotic collection encountered in 5% of the upfront group and 12% of the step-up group. In terms of the size, the mean transverse axis of the necrotic collection was 11.6 centimeters in the upfront group, 10 centimeters in the step-up group, and the extent of pancreatic necrosis was median of 50%, with infected necrosis encountered in 84% in the upfront and 88% in the step-up group. In terms of the disease severity at presentation, the majority of our patients had SIRS, 86% in upfront, 91% in the step-up group. And we had 22 patients with sepsis in the upfront group, with single organ failure in 41%, multi-organ failure in 30%. In the step-up group, 18% of our patients had sepsis, 27% had single organ failure, and 36% had multiple organ failure. The median Apache 2 score was 50 for upfront group, 16 for step-up group, and the majority of our patients were undergoing enteral feeding through a enteral feeding tube in both groups, 57% upfront and 61% in the step-up group. These are the outcome measures when you look at the primary endpoint of the total number of reinterventions required per patient to achieve treatment success at the end of 6-month follow-up. There was a significant difference between two groups with a significantly lower number of reinterventions required in the upfront group, with median of 1 versus 2, with a p-value of 0.0027. If you look at other outcome measures, there was no significant difference, however, in the treatment success, 100% in the upfront versus 94% in the step-up group. However, if you look at clinical improvement at 72 hours after index intervention, we saw this in 76% of patients in the upfront necrosectomy group versus 52% in the step-up group. And this was statistically significant with p-value of 0.035. Additionally, we believe this then translated to a shorter hospital stay, seen in the upfront group with median length of stay of 9 days versus 19 days in the step-up group with p-value of 0.048. When we looked at the mean adjusted total treatment cost, however, we found no significant difference, although in the cost was numerically lower in the upfront group, with mean adjusted total treatment cost of $446,000 compared to $715,000 in the step-up group. So we also performed a regression analysis to look at factors associated with the need for 2 or more reinterventions to achieve treatment success. And the variable that lit up when adjusting for patient demographics, presence of SIRS, extent of necrosis, and size of necrotic collection was the treatment strategy. When we adopted the step-up approach, as opposed to the upfront necrosectomy group, we were 8 times more likely to need at least 2 or more reinterventions to achieve treatment success. When unadjusted, and the odds ratio was 5.14 when adjusted, with p-value of 0.0027. These are the adverse events. We found no significant difference in the overall procedure-related and disease-related adverse events in the 2 groups. We encountered 11% of our patients encountered procedure-related adverse events versus 24% in the step-up group. This again was not statistically significant. The most commonly encountered adverse events was bleeding during stent deployment and during endoscopic necrosectomy, aspiration, pneumoperitoneum, and stent migration were all observed in the step-up approach. In terms of disease-related adverse events, so these are adverse events as a result of their underlying acute necrotizing pancreatitis, the adverse event rate was 32% in the upfront group versus 48% in the step-up group, with no significant difference between the 2 groups. Again, the same for mortality. We've encountered 6% mortality in step-up, 0 in upfront. Again, this was not statistically significant with p-value of 0.22. These are the limitations of our randomized trial. We included only patients who are amenable to endoscopic treatment in this study, and therefore findings may not be applicable to all patients with pancreatic or peripancreatic necrosis. Several aspects of endoscopic treatment are institution-specific. However, we believe that all our steps taken and procedures performed in the study were evidence-based and really standard of care when taking care of these patients. We included only patients with necrosis extent of at least 33%, and therefore findings may not be applicable to patients with less necrosis. We also did not design the study to power to show a difference in mortality, as our primary outcome measure was the number of reinterventions required to achieve treatment success. And we only use clinical endpoints to assess treatment success. We did not use histological markers to compare inflammatory responses between the two treatment methods. So the take-home point from this randomized trial is that in patients with infected necrotizing pancreatitis, an approach incorporating upfront necrosectomy at index intervention rather than as a step-up measure safely reduced the number of interventions required to achieve treatment success. And although there was no difference in treatment success or rate of adverse events, such an approach appears to expedite clinical recovery and shorten the length of hospital stay. Next is a randomized trial from the New England Journal of Medicine. This is a phase 3 randomized trial looking at the efficacy and safety of elafibranor in primary biliary cholangitis. Primary biliary cholangitis is a rare, chronic, cholestatic liver disease characterized by destruction of interlobular bile ducts, leading to cholestasis and liver fibrosis, and if untreated, can progress to cirrhosis and the need for liver transplantation. Currently, there's only one approved first-line treatment for patients with primary biliary cholangitis, and that is ursodeoxycholic acid. However, 40% of patients have inadequate response to this treatment, and actually up to 5% of patients have unacceptable adverse events to ursodeoxycholic acid. The only approved second-line treatment for primary biliary cholangitis is obeticholic acid, and less than 50% of patients actually have a biochemical response to this medication. So the authors looked at elafibranor, which is an oral dual peroxisome proliferator activator receptor, or PPAR alpha and delta agonist, which acts by decreasing the toxic effects of bile acids and inflammation through downstream modulation of nuclear receptor targets for PPAR alpha and PPAR delta receptors. The aim of this randomized trial was to evaluate the efficacy and safety of elafibranor in primary biliary cholangitis compared with placebo. So this was a multinational, multi-center, placebo-controlled, double-blinded phase 3 clinical trial. Patients who had primary biliary cholangitis who had inadequate response to or unacceptable side effects to ursodeoxycholic acid were included in this study. Patients were randomized in a 2-to-1 ratio to either elafibranor, taken at dose of 80 milligrams every day, versus placebo. And the primary outcome measure was biochemical response, defined as alkaline phosphatase of less than 1.67 times the upper limit of normal, with reduction of at least 15% from baseline and normal total bilirubin at follow-up at 52 weeks. So patients, 161 patients with primary biliary cholangitis were enrolled in the study, 108 patients in the elafibranor group compared to 53 patients in the placebo group. The majority of the patients were female, 94% in the elafibranor group versus 98% in the placebo group. Time since diagnosis was similar between the two groups, which is expected, 7.9 years versus 8.3 years in the placebo group. The mean alkaline phosphatase in the entire study group was 321, and the proportion of patients with alkaline phosphatase at least 3 times the upper limit of normal was 39%. The total bilirubin was 9.6 in the study cohort, and the worst itching score was mean of 3.3, and moderate to severe pruritus was encountered in 41% of the study cohort. Bridging fibrosis or cirrhosis was seen in 43% of the study cohort, and the mean liver stiffness was 10.1 kPa. These are the outcome measures. So the authors looked at biochemical response and also normalization of alkaline phosphatase. And as you can see, these are the biochemical response as determined by the number of patients. in each group, and at the end of 52-week follow-up, biochemical response was encountered in 51% in the elafibranor group versus only 4% in the placebo group. Again, p-value of less than 0.001, so this was statistically significant. When looking at the proportion of patients with normalization of alkaline phosphatase, again, elafibranor was superior to placebo, with normalization of alkaline phosphatase encountered in 15% versus 0, with p-value of 0.002 at the end of the 52-week follow-up. In patients who had moderate to severe pruritus, the least squares mean change from baseline through week 52 on the worst itch numeric rating scale, however, did not differ between the two groups, with no significant difference between the two groups, p-value of 0.2 and 95% confidence interval of the difference between their two scores of -1.99 to 0.42. When looking at adverse events during the treatment period encountered in the majority of the elafibranor and placebo groups, then the most common types of adverse events encountered in the study were abdominal pain, encountered in 11% in the elafibranor group, diarrhea, again 11% in the elafibranor group, also nausea, UTI, vomiting, fatigue, headaches, and back pain. Interestingly, these were all also encountered in the placebo group. Again, we had 6% of abdominal pain, 9% diarrhea, 6% nausea, 90% UTI, 2% vomiting, 13% fatigue, 11% headache, 11% back pain. Serious adverse events were encountered in 11% of patients in both groups. And adverse events were attributed to the trial regime in 39% in the elafibranor group versus 40% in the placebo. They encountered 2 deaths in the elafibranor group, 0 in the placebo group. The limitation of the study is that, not surprisingly, due to the demographics of this disease process, majority of patients enrolled in the study were white. And the take-home point from this randomized trial is that in this phase 3 clinical trial, comparing elafibranor with placebo, treatment with elafibranor resulted in a significant greater improvement in relevant biochemical indicators of cholestasis when compared to placebo. However, as we saw earlier, it did not make any difference to the pruritus score, the proportion of patients in whom their severe to moderately severe pruritus improved with treatment. And therefore, in conclusion, overall, elafibranor may provide an effective new second-line treatment for patients with primary biliary cholangitis. This is our last study. We are looking at endoluminal radiofrequency ablation in patients with malignant biliary obstruction. This was a randomized trial out of Czech Republic, published in Gut. Endoluminal radiofrequency ablation has been promoted as a good palliative treatment for patients with cholangiocarcinoma and pancreatic adenocarcinoma who have biliary obstruction. And is being increasingly used, especially with the recent availability of endoluminal RFA catheters. However, high-quality data reporting on the beneficial effect of RFA in malignant biliary obstruction from cholangiocarcinoma and pancreatic adenocarcinoma are lacking. The aim of this study was to investigate the impact of endoluminal radiofrequency ablation on survival and stent patency in patients with malignant biliary obstruction. So this is a multi-center randomized trial from the Czech Republic that enrolled all patients with histology confirmed malignant biliary obstruction secondary to unresectable cholangiocarcinoma or pancreatic adenocarcinoma, and patients were randomized in a 1-to-1 ratio to either undergoing biliary stent placement alone for their malignant biliary obstruction or placement of biliary stent with endoluminal RFA. Usually only one session of RFA was performed unless the stricture length was greater than 2.5 centimeters, in which case more than one session was performed. follow-up period was 12 months, and the primary outcome measure was overall survival. So what these authors did was they divided their patient population into patients who had cholangiocarcinoma and pancreatic adenocarcinoma and calculated their baseline characteristic comparisons and overall outcome measures depending on the etiology of the malignant biliary stricture. So if we look at cholangiocarcinoma, they enrolled 44 patients into the RFA group, 41 patients into the control group, which is biliary stenting only. And as you can see, as you would expect from randomized trials, there really should be no significant difference in baseline characteristics. That's the whole point of performing a randomized trial. So the majority of patients had bismuth 1, 2, or 3, stricture 9 patients in the RFA group, and 13 in the control group had bismuth type 4, malignant biliary stricture. 15 patients in the control group, 11 patients in the RFA group had stage 4 cancer. The bilirubin at procedure, the mean was 45 and 50. In the cholangiocarcinoma patients, prior stenting was performed in all these patients. Patients were undergoing concomitant treatment for their malignancy in 9% in the cholangiocarcinoma group, 20% in the control group. And the majority of patients had undergone metal stent placement, 89% in the RFA group, 73% in the control group. When looking at patients with pancreatic cancer, they enrolled 37 patients into the RFA group, 39% who had biliary stenting only, so that was the control group. The mean age was 72 in the RFA group, 70 in the control group. Bismuth stricture is not applicable. Everyone will be having a distal biliary stricture as a result of pancreatic cancer. 16 patients in the RFA group had stage 4 pancreatic cancer. 14 patients in the control group had stage 4 pancreatic cancer. Bilirubin at procedure was mean of 50 in both groups. Prior stenting was seen in 84% in the RFA group, 87% in the control group in the pancreatic cancer group. And again, majority of patients had a metal biliary stent in place, 97% in both the RFA and control groups had metal stent placement. 22% of patients with RFA were undergoing concomitant treatment for the underlying malignancy, and 18% in the control group. So when looking at survival, which is the primary outcome measure in this randomized trial, unfortunately, for both cholangiocarcinoma and pancreatic adenocarcinoma, performing endoluminal RFA did not improve survival at the end of the 52-week follow-up. In any of these patients. So if you look at the survival curve, this is the Kaplan-Meier survival curve here. The blue line is the control, so biliary stenting only. The yellow line here is the RFA. And again, you can see they run very close together. And when you perform a log rank analysis to look to see if there is a difference in survival, it is not. P-value 0.58. For pancreatic adenocarcinoma, again, the blue line for the control group, yellow line for the RFA group run very close together. And again, the p-value is 0.73. Adverse events were similar in the two groups. For cholangiocarcinoma, the adverse events in patients who are undergoing RFA included pancreatitis in 1, cholangitis in 3. They had 1 patient with liver abscess, 1 patient with acute cholecystitis. In the control group, they encountered cholangitis in 3 patients, liver abscess in 1. In patients with pancreatic cancer, the adverse event encountered in the RFA group was cholangitis in 1, and then in the control group, biliary stenting only, cholangitis seen in 3 patients. They encountered no other adverse events in the pancreatic cancer group, including pancreatitis, liver abscess, and cholecystitis. The limitation of this randomized trial is that the study was terminated, is what it's supposed to say, after interim analysis for futility and did not complete enrollment of the planned number of patients. Also, these patients have unresectable malignancy. A lot of these patients had advanced cancer, and the use of other anti-cancer treatment and anatomical ascent of disease can determine complexity and success of biliary drainage and can influence survival in patients with malignant biliary obstruction. And also in these patients, single session RFA was performed in the majority of these patients. So the take-home point from this randomized trial is that combination of endoluminal RFA and stent placement was not superior to stenting alone in prolonged survival in patients with malignant biliary obstruction. And based on this study, use of RFA in patients with cholangiocarcinoma and pancreatic cancer is likely to remain limited to clinical trials and further large randomized trials and further study as are needed with this treatment. So to recap, in this month's journal club, in patients with infected necrotizing pancreatitis, an approach incorporating upfront necrosectomy and index intervention rather than as a step-up measure safely reduced the number of interventions required to achieve treatment success. Although there was no difference in treatment success and adverse events, such an approach appears to expedite clinical recovery and shorten the length of hospital stay. Next, treatment with elafibranor resulted in significantly greater improvement in relevant biochemical indicators of cholestasis than placebo in patients with primary biliary cholangitis. Elafibranor may provide an effective new second-line treatment for patients with primary biliary cholangitis. Combination of endoluminal RFA and stent placement was not superior to stenting alone in prolonging survival in patients with malignant biliary obstruction secondary to cholangiocarcinoma and pancreatic cancer. And so based on this study, use of RFA in these patients should remain limited to clinical trials and proceed with caution. So this concludes our journal club for December 2023. This is last one for the year. Our next journal club is on January 3rd, 2024, 7 a.m. Eastern Standard Time. I want to thank everyone so much for joining us every month for the journal club. I really enjoyed discussing these studies with you all. Please have a wonderful December. Happy holidays, Happy New Year, and I look forward to seeing everyone in January. Thank you so much. Take care. Goodbye.